Our bodies contribute a significant amount to how we see ourselves and how we're socialized at a young age. Due to societal messaging on what bodies should look like, we've been indoctrinated with damaging principles like ableism, cisnormativity, and quote-unquote healthy body shapes. As we understand what gender is as children, we reinforce gender roles and what each gender should look like body-wise. Eventually, during puberty and into adulthood, we are confronted with more bodily changes that affect our idea of not only how we view ourselves, but how we view others. These ideas reinforce a norm that many of us don't fit or aspire to. This could not be more true for the intersex community or people born with differences of sex development. What is intersex? According to the Intersex Society of North America, any variety of conditions where a person has reproductive or sexual anatomy that differs from typical binary male or female anatomy may fit under the intersex umbrella. Being born with differences of sex development or with non-binary genitalia may also be used to describe what intersex is like. Not all individuals born with these traits may identify as an intersex person. In addition, not all individuals have their intersex anatomy or sex characteristics discovered at birth. For some people, it happens during puberty, and for others, they never know until they are autopsied at death. Doctors' opinions have historically swayed the majority view of how we understand differences of sex development, but this is no longer true. More and more, we are hearing from the intersex community about bodily autonomy and positivity. Why should we be judging someone or changing an aspect of their body based on societal conventions? Importantly, conversation in medical care for youth who have intersex conditions often requires becoming aware of new concepts, making decisions about how to raise the child, as well as if and when appropriate to proceed with any medical or surgical intervention. I'm joined today by two fantastic healthcare providers who I've also had the chance to work with, Dr. Whitehead and Dr. Papadakis from Lurie Children's Supportive Program for a Range of Urogenital Traits, also known as SPROUT, to discuss creating healthy discussion surrounding intersex traits and community. Hello, everyone. Super happy to be here. Today, I have two guests with me. That's exciting. That's a first. And our episode today is going to focus on the intersex community, or speaking about differences of sex development and all the other terms that fall under that umbrella. So I'm very happy to introduce our guests. First, we have Dr. Whitehead, and I'm going to read your bio. Dr. Whitehead, who uses they, them pronouns, is a pediatric endocrinologist at Ann and Robert H. Lurie Children's Hospital, Chicago, and an assistant professor of endocrinology at Northwestern University Feinberg School of Medicine. As part of the transgender community, Dr. Whitehead is passionate about improving access to and quality of care for transgender and gender diverse kids, as well as kids with intersex traits or differences of sex development. Outside business hours, they can usually be found playing in rec sports leagues, walking their two sassy dogs, or reading queer young adult fiction. So welcome. And then Dr. Jackie Papadakis, who uses she, her pronouns, is a pediatric psychologist at Ann and Robert H. Lurie Children's Hospital, Chicago, and an assistant professor of psychiatry and behavioral sciences at Northwestern University Feinberg School of Medicine. Dr. Papadakis provides care to kids with intersex traits or differences of sex development as part of Lurie's Sprout Clinic. In her personal time, she likes going on adventures with her two young children and spending time in the backyard or at parks. Yay! How are you both feeling today?
Doing really well.
Thank you so much for having us.
Yeah.
Yes. This is our first episode that's going to talk about the I in LGBTQIA+. And I think it's so important to discuss how the community is so diverse. And I really want to make sure that we're including everyone when we're having our discussions on health equity and we're talking about improving access to care and quality of care. So I want to give a little background about how I know you two, because as people have listened before, I am a medical student at Northwestern, and I had the privilege of shadowing in the Sprout Clinic earlier this May. So that was an exciting time. I had known you, Dr. Whitehead, before through our mentorship and faculty, student, organization, stuff related to that. But also, I got to meet you, Dr. Papadakis, there. And it was really exciting to see how the team, the interdisciplinary team, worked at Sprout Clinic. Well, let me ask either one of you, can you give me the name for Sprout? What does that stand for?
Yes, SPROUT stands for Supportive Program for a Range of Urogenital Traits. So it's an acronym, SPROUT.
Amazing, amazing. And I wanted to discuss a little bit about the name because when I shadowed earlier this year, I believe it went under a different name that was the Sex Development Program. And when we talk about using names and nomenclature that is respectful and affirming of communities, I assume that that went into the decision to change the clinic from that prior name to the supportive program for a range of urogenital traits. So I wanted to know what kind of discussions and conversations happened around the time of that name change. And was there any particular feedback from patients you were seeing?
That's a great question. So when Larry established the Gender and Sex Development Program, it was sort of an umbrella program that encompassed both the Gender Development Program, which is the gender care for trans and non-binary youth aspect of the program, and then the DSD program was sort of under the same umbrella. But these two programs have grown enormously over the last 10 to 11 years since they started. And they're largely different patient populations, although there's a little bit of overlap. And there's different groups of providers and different specialties and different healthcare needs that each population needs. And so we felt it was kind of ultimately time to split them into sort of two programs. And with that came the opportunity to do a little bit of like rebranding and get a cute new logo and things like that. So we took full advantage.
Yeah.
We looked at other programs across the country to see what they had used as their names. And several had similar kind of acronyms that were a little bit more on the not using the word sex, for example. So we were originally called the Sex Development Program, which a name with the word sex in it, it sort of gives an interesting vibe to what we're doing, which is encompassing much more than just
Sex development.
Sex development. Yeah. So we're really taking care of the whole child or teenager and their whole family. And so this name is meant to have more of a neutral to positive spin on being a supportive program and then taking care of a range of urogenital traits, not just necessarily people who identify as intersex or patients with diagnoses that are under the classic and more narrow umbrella of what intersex is.
Wonderful. Anything else to add?
No, just that I think we all wanted to have a name change for a while, but sometimes these things do take a while and administratively. So we are happy to have a new name now, but it's something I think we'd all been mindful of for quite some time.
Yay. I'm glad. I'm glad that it's been not a difficult transition to get a new name as well. It sounds like that was a process that was collaborative and was due to happen for some time and is more affirming now that we know that we're taking care of not obviously people who are just going through sex development. There's so much more to that with youth and just growth in that time, and also talking about families and like how you're also supporting families. Because one of the awesome things I saw was you all were having conversations with the parents. Really. And I want to mention that in the clinic, the focus is on youth. And so we're not talking about right now adults or any sort of teenagers or adults who may come to identify as intersex. We're talking about children who are 2-3 months, maybe older. Would that be correct?
Yeah, I mean, I would say we see patients of all ages, right? Actually, even starting from prenatally, we'll be talking with parents who their child is not yet born, doing a consult on prenatal testing that has given some information about this baby's genetics and what that may mean for them in the future. So we'll do consults as early as then before this young person has been born. And then we have, some of our patients come to us, they're already a young adult. And so although we're a pediatric patient, I mean, not often, but late adolescence or even, early adulthood, I think we've had some over 18 who have come to us for the first time because there's not necessarily multidisciplinary programs in the adult world, unfortunately. These programs really exist in the pediatric setting. So, yeah, and obviously when patients are younger, whether it's prenatal or infancy or toddlerhood, of course we're engaging with them, but it's really the bulk of our relationship is with parents. And then, of course, as babies and children get older, we are able to involve them more and more in their care. And I mean, the goal is always to have them at the center of it. So.
Absolutely. Absolutely. That's a great response. I didn't know that. Yeah, you're meeting people from even before families are having a child to people who are young adults and are wanting to discuss their situations. So I want to say as well that your backgrounds are centered around pediatrics and working in Lurie Children's that we say here. But I'm curious to know how each of you began work in this space, because what are each of your earliest experiences wanting to work in LGBTQIA plus health or with the queer community? Was this sort of your first experience in healthcare, getting a job in this area, working with the community? Or did you have prior experiences like wanting to say like, oh, I do want to serve this population particularly?
So I didn't have a lot of experience before my current job. When I was in college, I had an internship at Howard Brown Health in sexual health education and really enjoyed that. That was for a semester, but I didn't actually start working with folks with differences in sex development or intersex until I got the job that I have now, which is the first job I took out of training. And I'm so grateful because I didn't honestly anticipate just how rewarding it would be and how wonderful it'd be. And I'm trained as a pediatric psychologist, which means that I'm trained to kind of apply certain concepts across different populations, you can say, whether kids have chronic illnesses or not, or mental health concerns or not, or whatever it may be. As a psychologist, I try to apply the same thing. So although the DSD intersex community was actually a new group for me to work with, as a pediatric psychologist, I apply kind of the same things. And then I've obviously learned a lot tremendously over the past 4 to 5 years. And a lot of that is because of the team we have at Lurie and how collaborative we are and how much I think we're always learning from each other and from our patients and families. So it's been really wonderful.
That's great. That's great. I'm glad it's been working out. How about you, Dr. Whitehead?
Yeah. I realized that I was queer in high school and I was on a pathway towards some sort of career in the sciences, but that's really broad. In college, when I learned more about the kind of current state of LGBT healthcare in this country and more about queer history and how the healthcare system and the mental health system had been sort of actively discriminating against the LGBTQ plus community forever, that's when I really realized that medicine and specifically being an affirming provider in the medical field was what I wanted to do. I knew that very early on, but in terms of exactly how to carry that out, what specialty to go to, whether to go to graduate school versus medical school, that was a longer process. But ultimately, I'm very happy with where I ended up. And I'm so happy to work with the amazing team that we have at Lurie.
Amazing. That's great. I want to say kind of similar. I feel so my path is obviously similar to Dr. Whitehead. I'm in med school, but I want to say, I mean, I was a psych major and I love psychology. So I think what you do is awesome. Dr. Papadakis, honestly, if I wasn't going to be in just medicine, probably also do, maybe psych is for me, psychiatry, who knows? But I think it's so awesome what I saw because there was a whole team at play at the clinic, the Sprout Clinic. It's not just you two, but I also saw genetic counselors, I believe. I also saw people who are working on research and recruitment for research or educating, simply maybe not recruiting that person then, but educating about research, right? Because there's still so much that we don't know about people in this community and rather differences of sex development and all of that. And then as well, I believe there was a urologist there. So there's so many people, but it wasn't overwhelming in the sense that you had everyone in the room at the same time. People came in and out of the room and there were frank conversations that were going on about how are you navigating this? What are your thoughts about what we've talked about today? And are you getting any sleep? These are new parents and it's oh, how is that going for you? So many things. So there's a long history of medical institutions intervening on the bodies of children born with intersex traits without letting children decide for themselves later or even considering the input of that child's parents. This has had huge implications today on policy that is shifting away from these interventions, whether medical or surgical, given that they may cause more physical and psychological harm than good, and they may be considered forceful and unnecessary. So, with that background, I want to get into a little bit of misconceptions that you all have heard or are interested in debunking today that are spread in society regarding these interventions that are being done or how discussions about the work that you do could be also involved in this discussion of intervening in children's bodies or talking about the intersex community and differences in sex development. So, any misconceptions that you'd like to debunk about what you've heard about the work that you're involved in?
I think the first thing we should say is just that this is a very, very, very controversial topic. And I want to say that what we think and say today is based on the medical knowledge that we have at this time and sort of based on the way that our society functions and thinks of things at this time, and that can change in the future. And that I hope that we do gain better medical knowledge to guide these decisions in the future. In terms of misconceptions, I think one of the biggest things is that the general public doesn't even have a conception that these surgeries or interventions occur, or that intersex people or intersex traits even exist. I think the general public's average knowledge of these topics is just very low. And I think that's a hard place to start from for some of our conversations. If they are aware that intersex traits are a naturally occurring phenomenon, then they may not have the knowledge that there is controversy around surgical decision-making, and they may not recognize that there could be long-term implications of the surgery decisions that are made.
Yeah, thank you so much for that response because starting with the idea on how our society even acknowledges that there can be intersex traits that we all don't necessarily, we're all diverse, right, in terms of how our bodies look. And I think one conversation that the intersex community is bringing up as of recent is talking about how bodies can be diverse and how that should be accepted, right? And that conversation. So, frankly, what you're talking about is the denial that intersex traits exist, right? That a range of urogenital traits, which is like a more medical term, but a range of urogenital traits can exist. That starting with that acknowledgement is important in this conversation. And I want to also say that Lurie Children, as of not too long ago, did release a statement about this matter, if I'm correct, and did say that they would no longer, and correct me if I'm wrong, but they would no longer move forward in performing surgeries around the time of birth regarding changing any intersex traits. Is that correct?
It's a little more nuanced than that, as opposed to a across the board statement of no surgery. So first, I think it's really important to separate surgeries that are done on gonads, meaning like ovaries or testes or ovotestes or streak gonads. There's some different ways that gonads can exist as well. But there's surgeries that are done on gonads for management of potential tumor risk, potential hernias, and to balance like the function of the gonad or the potential future function of the gonad for hormone production and fertility with the potential for germ cell tumor development. And there's not perfect data on risk benefit of doing anything with gonads, and it differs based on what the specific genetic diagnosis is for each patient. And so there's a lot of decision making to be done around what, if anything, could or should be done about moving the gonads to a different location or removing them from the body. And then there's a whole nother category of surgeries that involves more of what you might say is like a cosmetic or procedure on the external genitalia, meaning like relocating the place where the urine comes out, where the urethra is, changing the size or the shape of the clitoris or the labioscrotal folds, other aspects of the external genitalia. And that's the part that the policy that Lurie released specifically referred to, meaning that our team will not at this time do what's considered an irreversible surgery on the external genitalia, meaning will not remove tissue, so the clitoroplasty specifically.
I was just going to add that at Lurie, it had been some time since we were doing such surgeries that Dr. Whitehead mentioned. It was really just we maybe didn't come out with a public, explicit statement announcing that we weren't doing this until the community, asked for that. And then we came out with this statement. But I think it's important to know that it's not that we were doing those procedures and then came out with the statement and stopped. We hadn't been for some time. So I think that's sometimes the complicated nature of some of this stuff is just, oftentimes in medicine, and it's not like we're always making public statements about standards of care or communicating to the public how we go about things. That's just not kind of in a lot of fields of medicine. And so it wasn't till I think the community really asked for some more transparency that we released a statement like that explaining like what we are doing. Do you feel like that's fair, Dr. Whitehead?
Yeah, and I think that's actually a really important point to add.
Yeah. Mm-hmm. Yeah, and I guess I would just add that, this is really, it's difficult work. And you had asked what are misconceptions. It's very complicated and it's very nuanced. Even two people with the same diagnosis do not have the same medical decisions to make for themselves. And I think that's the most important thing to kind of highlight is that if this seems too easy and simple, like there's probably more that needs to be considered. And I think what Dr. Whitehead said is really important is that, because most people don't have the awareness that they should about intersex and differences in sex development. And, hopefully we're changing that, right? But that without even that foundational knowledge, it's really hard to. And, I'm not a geneticist. It took me a long time to even understand genetics and in utero sexual development. These are complicated things. And sometimes you do kind of need to kind of understand the whole picture to really appreciate what's going on. So, and you can't expect everyone to know everything. And I do take responsibility as medical providers. It's our job to make sure we're communicating, not just to patient and families, but to, the larger community and public about what we're doing and why we're doing it, et cetera. But with that, I probably should sign off for an appointment I have. But thank you, Renee, for inviting me here. And sorry I cannot stay for the full conversation, but I look forward to listening to the rest of the conversation when this is posted. So thank you.
Of course. Good luck with the rest of your day. Take care. Yeah.
I thought of another misconception.
Yeah.
And it's sort of on the flip side of sometimes when children are born with a difference of sex development that affects the way their external genitalia appear, sometimes families seek medical care in such a way where the general vibe is, we want you to fix this, meaning we want our child to have a surgery to make the genitalia look more typical for a female or more typical for a male, depending on how they're raising the child. And what they don't necessarily understand is that there are implications of that long term, meaning they might have surgical complications that may require additional surgery in the future. They need long-term follow-up with specialists to continue to monitor for that type of complication. There's all sorts of considerations around whether or not to have surgery. And I think one of the misconceptions is that it is sort of a straightforward decision when, as Dr. Papadakis just said, it is much more complex. And if it seems straightforward, then we're missing some pieces.
Yeah. Thank you so much for all those statements about misconceptions and sort of approaching those conversations. I think we do live in a society where we are raised and socialized to understand bodies and gender in a particular way for what a boy should be, for what a girl should be. And I'm really loving that now more and more, especially from the younger generation. And we're hearing about being proud to be non-binary, gender non-conforming, but also accepting bodies that are not necessarily typical and moving forward with that and empowering people with that. And so maybe fixing isn't the right word, right? Maybe there are other words that we can use to address the differences that our bodies have, and making lives for people who have differences in sex development better for them, because everyone has a unique situation. And so I think when somebody says fixing a particular external factor of genitalia, that doesn't mean that that's going to give the same sort of outcome, or that's the same want for someone else. So, yeah, I wanted to also ask, in the same way that you kind of address the term fixing as sort of a misconception for addressing these traits, I wanted to also say, what are your thoughts on the word treatment in reference to these operations? Typically, we learn in medical school, like you get a diagnosis, there's a treatment. And so, or maybe not, there's a treatment for it. So I'm kind of curious about that term. Is that a word that you use when you talk about any interventions and when you're talking with patients or the families?
Yeah, I think nomenclature in general is a really interesting topic in this field and then also in the gender world, because people are kind of constantly inventing new words, and I think new words and new descriptors sort of get us closer to the truth.
Yeah.
Personally, I don't have a lot of strong feelings about treatment as a term. I think that there's definitely some terminology in this field that we've moved away from aggressively, such as
Yeah.
disorders of sex development, as opposed to differences of sex development. A newer terminology shift is happening to refer to variations of sex characteristics. And again, these are all meant to be less and less stigmatizing, meaning it's not necessarily a disorder in the way your body developed, it's sort of a naturally occurring difference in the way the genitalia looks or something like that. So as far as the word treatment, I don't know. I haven't heard a lot of discourse around that specific word. It's a totally fair question. I'm open to hearing other people's experiences with how that goes or how they feel when it's referred to. As an endocrinologist, the main sort of treatment that I think of being medically necessary is some sort of hormone replacement. So if someone has a condition in which their gonads are not making either estrogen or testosterone in sufficient quantities to support like growth and bone density and sexual function and things like that that are both medically and psychosocially important to many people, then a treatment would be replacement of those hormones.
Yeah, I agree. I agree. I think that what you're saying about the hormones is pretty fair. Obviously, you're endocrinologist, so that's what you're focused on, a big part. So I would say there's aspects of it, right? I think you also did mention sometimes there can be a risk when you have intersex traits. There can be a risk for any gonadal cancer in the future, whether it's small or big. And so to some degree, that can be considered a treatment if that is addressed with a intervention, either medically or surgically. So, yeah, I think it's an open conversation to have. And as we see more and more, when we discuss what historically have been diagnoses and we move closer to communities that are reclaiming those words and are being empowered in who they are rather than being diagnosed with something, I think we'll start to see a change in how the medical community then responds to that feedback. So,
One further thought about that, and I guess to me, when I think about treatment versus no treatment, treatment to me means like we're taking care of a thing, something,
yeah,
versus no treatment is sort of like we're just ignoring it.
yeah,
And for example, in the case of a risk of tumor in the gonads, one treatment option would be to remove them. One treatment option would be to monitor them with imaging every so often. Another treatment option might be to relocate them to a different location surgically so that they can be palpated or more easily monitored. Ignoring them is not a good option, in my medical opinion, right? And so
yeah,
doing nothing is not, if someone is seeking care and is engaged in medical and surgical follow-up care, then we don't want to be ignoring. Like, I think everyone deserves to have treatment and they deserve to have a conversation around what their treatment looks like. And their
yeah.
treatment may look like no surgery, but it looks like doing hopefully something else to try to keep them as healthy as they can be.
Oh my goodness, such a great point, right? I think what you're talking about is there's potential for other, maybe not indirectly intervening, but still making a decision to watchfully wait or to incorporate a different perspective, right, in terms of treatment. And even that word, right, does not necessarily mean as specific to an intervention as it might mean. It could not mean that. And then that would also be a treatment in itself, considering what the medical team decides. So, absolutely. Thank you. Yeah, I wanted to also discuss community and how community has advocated for change. So, a number of organizations exist across the US and world representing the community of intersex people and embracing the I and LGBTQIA+. I also want to say there's an organization called Interact, which also, I don't know if you've heard of the Interact organization. Okay, so they seek to empower intersex youth and advance their rights through advocacy, public engagement, and fostering bonds between people. And I wanted to ask you personally, what is the importance of organizing with communities themselves, and what does that mean to you, and getting their voices involved in the work that you do?
Yeah. I don't want to speak on behalf of the intersex community by any means, but I think that hearing from some patients and people in the intersex community, they have found a lot of support and positive benefits from having these sort of community spaces and groups with people that have had similar experiences, for better or for worse, sharing resources, just feeling like you're not alone. I can speak for myself in terms of finding a queer community that's been really beneficial for me. And so
Yeah.
I think however and whatever type of group that someone finds that where they feel like they have something in common and are not alone and have support is really important for kind of whatever aspect of life, healthcare related or not, that you're talking about.
Absolutely.
Yeah, I think this is complicated as well, but there's often sort of this conflict that there's the advocacy and support groups on one side, and then there's the medical providers on the other side, and that they're against each other. And I don't think that that is true now, and I don't think that it needs to be true in the future. And I think that there's more that we can do to bridge the gap, because ultimately what we all want at the end of the day is for everyone to get the best medical or surgical care or lack thereof that is best for them. And we have different ideas about how to go about that. And we're also, all of us are working with an incomplete set of data, meaning the data out there on what is the perfect treatment protocol for XYZ diagnosis does not exist. Like, we do not have perfect medical data on tumor risk or hormone profile or fertility or gender identity, etc. And so
Absolutely. Yeah,
I
we don't. We don't. And we start from our experiences and what we've learned, either in training or education or somewhat. And then we build upon that through more discussions and more learning. And I think having this conversation does require a certain openness to learn and a certain interest in engaging with community, because I certainly would not want to speak for the intersex community themselves, but I want to say that I also want to feature people from the community on the lived experiences portion of the podcast, because while we have this conversation, obviously there's a conversation to be had with people who identify in that and have done work around that. And so also that conversation about the medical providers being on one side and anyone who's an advocate or encouraging empowerment in the community is on another is a misconception in itself. And I think it's also affirming to have you in the healthcare system, right? As somebody who's trying to bridge that. And we can have people who are allies in the system and stuff. So yeah, for sure, for sure, for sure. I appreciate that. Going forward too, as well, I wanted to say that I was impressed by the patience and the openness of the conversations that I shadowed while we were with patients at the Sprout Clinic. You and Dr. Papadakis were listening to the concerns and questions of parents, and we've already discussed how there's a whole multidisciplinary team dedicated to meeting the medical, social, and psychological needs of families and the youth. So I'm curious to ask you, how do you manage these conversations with the parents? in terms of approaching any sort of topics where they may not have a lot of data on it in their minds, or they may have a lot already? And what would you say your role is on the team in helping parents process their child's diagnosis?
The first thing that I can say is that every single family is different. And so if you've seen one conversation in our Sprout Clinic, you've seen one conversation. And going into every room when you're meeting a family for the first time, you don't necessarily know how the conversation is going to play out. And so I think we go in with an open mind. And one of the first things we want to understand is sort of, what does the family know already? What are they particularly worried about? Or what questions do they have for this particular visit? What's sort of top of mind for them? And what is their understanding of their child's condition at this point? Do we have a very specific genetic diagnosis? Are we looking for one? Has there been any testing done? Basically, at what point are they in sort of the life course, basically? Because people can come into our clinic at any stage, like Dr. Papadakis mentioned, from prenatal visits to young adults.
Yeah.
And so as an endocrinologist, my role is mainly focusing on what sort of hormone testing or treatment may or may not be needed, understanding sort of how the hormones in the body are working. The surgeons, the urologists and pediatric surgeons are also anatomy experts. And so they're thinking about, are there any issues with urinary function, sexual function in the older population?
Yeah.
Things like that. And there is no one in our clinic that could do this job all on their own. We really all need each other. We need our counselors, we need our social worker and our nurses, we need the surgeons, we need the psychologists, and all of us kind of working together and sort of playing off of each other. And I think, for example, if I'm having a medical conversation with a family, sometimes someone like Dr. Papadakis will sort of jump in and be like, Dr. Whitehead, I didn't understand what you said when you said that fancy medical word. And I went, oh gosh, you're totally right. Thank you for interrupting me. Back up, explain that better. And so sometimes they can sort of play a role of like encouraging the families to ask questions and to sometimes things come up after one provider has left the room where the family is more comfortable saying whatever their question was or bringing up a specific topic to a different provider. And then we can all kind of come together and regroup and ultimately, I think, provide what we hope is always striving to be really good medical care.
Absolutely. I think that's great that you're acknowledging, one conversation is one conversation, and that also you all are in the room checking each other in a polite but also like encouraging way, like, oh, I don't understand that term. Yeah, or have we addressed this topic today? Is this something that the family would like to talk about too? So seeing that model of care with multiple team members coming in and out the room, addressing any questions was a first timer for me. Usually I just kind of went in the room when I was shadowing, I just went with the doc and that was kind of it. So I'm curious, would you suggest that the model of care that you all are involved in is one of the best, or has it been studied at all as being very helpful when we're talking about working with this specific population? Or do we not know enough? And is there more work to be done to understand how best we can serve patients?
That's such a great question. It's sort of hard to study the model of care, but anecdotally, a lot of families seem to really appreciate that they get to see lots of different providers on the same day. It's a long appointment. They might be there for a couple of hours, but they know that they don't have to wait after the appointment or go to 4 different offices to get all of their doctors to kind of talk to each other. We're all kind of there sitting in the same room at the same time. I guess from a higher level administrative standpoint, you might say that that's not the most efficient because those visits take a longer time. I don't see 16 patients in a day.
Yeah.
But it's higher quality care. And we think that it's worthwhile to do that for these rare conditions. And I'm biased because this is the system that I was trained in, and I work here as a faculty member now. There are other clinics throughout the country that have a similar model where it's kind of one team, but they may not be in the physical clinic on that same day, but they still work together and collaborate closely. And then there's other models that are significantly more fragmented. And I think that's probably one of the more common situations, just given sort of the fragmented nature of a lot of medical care in our country, unfortunately. We have the privilege of having, 10 doctors in a room on a Friday afternoon twice a month. And there's a lot of barriers to getting that to happen on a,
Yeah.
hospital-wide level and in different places throughout the country, geography, et cetera. So I think I don't want to call it out as the one ideal model when it may not be a realistic model in other locations for different reasons. But I think that it works well for our team here. So I'll say that.
That's awesome. Thank you for that honest feedback on that. And yeah, I would venture to say, yeah, there can be difficulties in terms of getting into a clinic like the Sprout Clinic. If you are living in an area where it's rural, or you are even in a country where having intersex traits is unfortunately stigmatized or not accepted, and that can be isolating and can put somebody in a situation where they don't want to even talk about it in a healthcare appointment, or they may grow up later on, and that's something that they may feel ashamed or even embarrassed about. And I think that when you start with youth and when you start at a young age, I think that it kind of opens the conversation for families to even get involved and to even explain to their children like what's going on and have it be more affirming than stigmatizing. And so I really do hope to see more, if not the specific model of care that you do, more clinics like Sprout that are appearing for the intersex community, because I think that that's super important, or people who have differences of sex development. So with that being said, I want to shout out the Intersex Awareness Day is October 26th. So I'm going to post on the social media about it. And I think that that's going to be a great way to educate, to talk, and also to share some clips from what we've talked about today. I think that will be informative. So I'm ending towards my last question. And I wanted to ask particularly about kind of future involvements. Where do you see your career headed and advancing care for children in this field? Do you see yourself continuing to mainly be in the clinic and doing that work, conversing with families, talking diagnoses, etc.? Or do you also see yourself getting more involved in like higher up, either like education? I know you're also an educator, so I mean you're already doing that, but either getting involved in like more advocacy or more policy. Where do you see yourself in this field?
That's such a fun question because I feel like I'm very early in my career and I could do anything at this point.
True.
I I think clinical care is really the most rewarding. That's when I get up out of bed in the morning and I say, I get to see some really cool kids in clinic today, and I get to help them understand and learn about their bodies and their medical conditions and how to take care of themselves. And I just find that really rewarding. And at the same time, there's a lot of research opportunity in this field. And there is so much that we wish that we knew and that we're trying to learn.
Research as well. Absolutely.
Really cool research going on in the fertility preservation space
Okay.
that I think could be very, very cool and applicable to people with intersex traits that maybe currently do not have the opportunity to have genetically related offspring, children, but that may
Yeah.
be able to in the future.
Okay.
And then I think you're absolutely right that there's a lot of room for advocacy and education in this field. And so at this moment, I have like a little bit in each of those arenas. And I guess it'll just be interesting to see where my career goes.
Yeah, yeah. Well, I'm very glad to work with you on a project before. We've worked on a little bit of research before, and I've also gotten the opportunity to shadow what you do, and it's really awesome. So I think it's really inspiring to see that you wake up and you're like, oh, I'm gonna really see some great kiddos today, and I'm gonna be able to help out with questions and help families and assist with those types of things. I think that's great. And finding your reason and how you can get involved in this whole arena. So we definitely need more LGBTQIA plus affirming providers. And so I think that that is super great. And I'm excited to see where you and Dr. Papadakis, who had to leave early, but also how she also continues to get involved. So anything else you wanted to add on our conversation today before I close?
I think mentorship is another one of the areas that's also super rewarding. And so
Yeah.
involved a little bit with, medical education and stuff, but just mentoring the sort of the next generation of medical providers that are going to carry on this type of work is really cool and fun. And there's so much that we could have talked about today. We talked about so many different things, and there's so much more. And so I know you've got some resources that you're probably going to shout out at the end, but if you need more, I'm happy to send. There's a couple of really good podcasts that are out that are touching on some intersex topics. Like there's one on gonads from Radiolab that's really good. And there's a couple other ones I can send, but there's just so much to talk about. And I'm really grateful to be asked to have this conversation because it's been really fun. And I think there's just so much room for more education in this topic.
Of course. Well, I'm going to first start this episode by having an introduction on bodies. So I think I'll get a little bit more into that and how there's some societal messaging on what bodies should look like that we have been indoctrinated with. And then also talking about what is intersex and how does that also get into this conversation and how we are accepting of our bodies. So that's another conversation that I'll try to add in there. But ultimately, I think we've discussed a lot. And I think that this will hopefully be helpful for people who don't know someone who has intersex traits or has never even discussed about what intersex even means. I think this is like a great starting point. And just hopefully anyone listening in, please feel free to interact more about this conversation and give your thoughts. So I'm so excited to release some clips from here. And I really appreciate your time. We need to align the intersex community under groups within the LGBTQIA+ umbrella that require more equitable care and attention. The decision to make choices about one's body for people born with differences of sex development echoes the sentiments from other human rights/social justice movements, such as under the reproductive justice, disability rights, and civil rights movements. Although some conditions resulting in intersex traits may require treatment for a hormonal imbalance or prevention of cancer risk, it's important to acknowledge that conditions that are benign medically certainly do not require doctors to make paternalistic decisions to intervene. Moving away from this viewpoint and promoting bodily autonomy will allow more fair and considerate healthcare decisions made in this community. Doctors Whitehead and Papadakis both have great passions for helping youth and their families understand both medically and psychologically the experience that comes with each patient's condition. Their collaboration, along with other providers, serves to decrease costs for making appointments, reduce wait times for different doctors, and lengthen counseling for youth and/or families that have questions to their healthcare team. While clinics like Sprout do not exist everywhere in the country or world, feedback from patients at this clinic will be telling of how supportive the program has been and can be in other areas. Thank you for listening in. If you would like to read more about the supportive program for a range of urogenital traits, type in Lurie Children's Sprout into your web browser. Also, to understand more about the meaning of intersex, visit isna.org/FAQ/what_is_intersex. You can find references for our conversation in this episode's biography. If you want to hear more content, watch clips, and give your thoughts, let's continue to push the conversation on Instagram at Equerity Podcast, Twitter at Equerity Pod, or on TikTok at BEQ Pod. If you like what you heard today, please give us a quick star rating on your preferred listening platform, and definitely subscribe if you're on the YouTube. Take care and see you in the next episode.